Okay, good afternoon to everybody, or morning or evening, whatever you are around the world. Welcome to the CSF section, our first webinar, and it's our pleasure really to have with us Marek and Sophia from Cambridge, who are the most productive husband and wife team I know in academia, who have published more than 140 papers on this very subject, and they're going to talk to us on who needs a shunt, who needs a revision, and about CSF dynamics and their perspective. This is largely around infusion studies, but the basic principles and the science behind it. So it's a pleasure to have you talk to us about this. Before we start, I'd just like to welcome all the participants and say that this is the first of many webinars for the CSF group. And we have others lined up, such as for Chiari malformation, and we're going to do two on that, one on its basic management diagnosis principles, another on operative intervention. We've got two lined up for normal pressure hydrocephalus, post-hemorrhagic hydrocephalus, and we're going to be discussing at length a new classification proposal for hydrocephalus, which is a long-term project. Some very eminent people will be joining us from around the world, so it's very, very exciting, and several more to come, which I won't expand on at the moment. And the CSF task force came into being late last year under the banner and auspices of the European Association of Neurological Surgeons, following acceptance of a proposal. And we are delighted to say, in a short space of time following its inauguration and getting the basic work done on this platform, within a short space of time, we've got membership from 37 different countries and over 140 members. And we invite all the members so far to please kindly make sure that they've joined the EANS, and more to join from the 1,800 EANS membership who would be eligible. So welcome to you once again. I also invite questions and answers from those who are joining to please put those questions at the end for the presentation. You can put them forward earlier, but it's the end of the presentation where we will focus on those questions and put them to Sophia and Marek. Welcome once again. Marek, Sophia, please welcome and make a start if you wish.
I need to share a screen.
Yes.
And it says host disabled participate sharing.
Anna, would you mind allowing Marek to share the screen, please? Anna, if you could allow that, I'd be grateful.
Yes, please, it's done.
Thank you. Marek, do you want to try to do that?
Yes.
Okay. And please bear with us for these little simple mishaps on our first one. We should be fine.
Do you see the screen?
Not yet.
Not yet?
No.
Oh, God.
Okay.
You don't see a screen?
No.
Marek,
Anna, would you be able to help?
Yes, click on the green button below.
Yeah, I did it.
Once you click on the button below, you should choose the screen you want to share. It asks you to do that. Do you want to do that? Can you do that? Should be the same. Okay, I think that's doing it. Well done. That's excellent.
Fantastic.
Okay, not to worry. Just like our rehearsal. Super.
Yeah, don't worry, don't worry. Don't worry. So
we've got many guests who are already saying
options, laser. Okay, great. So we can start. Sorry for these delays.
Good afternoon. My name is Sofia Czosneka.
And my name is Marek Czosneka.
What a provocative title.
In fact, it's not that much provocative if you think with us. Don't pretend that we know everything on hydrocephalus to decide who needs a shunt and who needs a revision. Because everything we will be talking about today will be talked about from the CSF dynamics perspective. And this is very, very peculiar perspective. It's not what you, doctors, neurosurgeons, or neurologists see when you see your patients in the clinic. It is perspective which is very limited. First of all, before I start, we go to disclosure. This is ICM Plus license software fees and so on and so forth. Some consultancies. Another part of disclosure is that we are a married couple. That's important. Hydrocephalus is far more complex than disorder of CSF circulation and CSF dynamics. Here we have something which I call clinical axis. This is what doctors see seeing the patient. First of all, they see imaging, and obviously ventricles are dilated in most cases, and clinical symptoms of hydrocephalus, how patients walk, urinary incontinence, memory, and so on and so forth. 66% decisions, and the good decisions about the shunting, is done by this axis. But what about 34% of the patients? In these cases, when we don't see the clear picture, we need to support our decision with investigation into CSF dynamics, alteration of CSF circulation, and if this doesn't help, alteration of cerebral blood flow. Also, in those patients who are coming to the clinic because of possible shunt malfunctioning, we need to know in which cases shunt revision is necessary. And that will be the part will be covered by Zofia. Tony Marmaru had a very peculiar background because he was an electrotechnical engineer. So this is why he built his famous model of CSF circulation in terms of electrical model. Here we have CSF formation of cerebrospinal fluid presented as a current source. Fluid is flowing, flowing, flowing to this point where we can measure intracranial pressure, and then have two branches. The one branch is absorption of cerebrospinal fluid. This is unilateral absorption through the resistance to CSF outflow to sagittal sinus. Therefore, here is a voltage source equal to sagittal sinus pressure. And another branch is compliance of cerebrospinal fluid space. Certain amount of fluid can be stored in nonlinear compliance, about which we will be talking in details in a moment. And here is a reference P0. Tony Marmaru envisaged this reference pressure equals 0, but we try to extend this way of modeling. Little bit of mathematics, but very simple mathematics. Don't be scared, please. First of all, relationship between cerebrospinal fluid outflow and cerebrospinal fluid pressure. Davson equation shows that when the pressure is lower than sagittal sinus pressure, intracranial pressure is lower than sagittal sinus pressure, there is no outflow of cerebrospinal fluid. Where the pressure increases above sagittal sinus pressure, outflow is linearly changing, increasing with a difference between cerebrospinal fluid pressure, ICP, and sagittal sinus pressure. If the resistance to CSF outflow is higher, gradient of this line is lower. If we plot on this line, horizontal line, equal to formation rate of cerebrospinal fluid, approximate 0.3 mils per minute, we see that the working point, this is this point, is traveling to the right. So increase in resistance to CSF outflow produces increase in baseline pressure. That was first part, Tafson equation. Then we can talk about brain compliance, this capacitor sitting in a second branch of the circuit. Therefore, if intracranial pressure is higher than certain imaginary optimal pressure, and I don't know why optimal pressure that has been called. I only remember that that has something in common with the opening pressure of the shunt when programmable shunts appeared on the market. So that was advised as initial setting of programmable valve. This is why it has been called optimal, but I'm not sure whether that has been supported by further studies. So when the pressure is lower than optimal pressure, compliance is constant. When the pressure increases above optimal pressure, pressure compliance decreases inversely proportional to difference between pressure and certain P0, is reference pressure. According to Marmaru, once again, that was 0. Elasticity is a parameter which characterizes how fast this decrease in compliance takes place. Dual to this compliance versus pressure relationship is a very well known pressure volume curve. This is rise of intracranial pressure. And here we have added volume to the system. We start from this optimal pressure, and above this optimal pressure, pressure volume curve is exponential. Higher elasticity produces higher steepness of this curve. But below optimal pressure, pressure rise is linearly changing with added or withdrawn volume. So this is whole pressure volume curve, linear, exponential. Here we can tell that compensatory reserve is good. And here compensatory reserve is exhausted. So we have we have two states: good compensatory reserve and disturbed compensatory reserve. And also dual to this pressure volume curve, there is a relationship between pulse amplitude of intracranial pressure, we call it AMP, and mean intracranial pressure. Where we rise intracranial pressure during infusion tests, we always see that the AMP increase with mean intracranial pressure. This is a pressure recorded during infusion test. Above P optimal, so this P optimal is a very, very important parameter. Amplitude increases proportionally to rise in ICP. Below P optimal, amplitude is independent on intracranial pressure. That will be end of mathematics, this 4 relationship. Tafson equation, compliance versus intracranial pressure, pressure volume curve, and the relationship between pulse amplitude and mean intracranial pressure. We're going further. We want to do analysis of this Tony-Marmaru model and identification of all parameters, because we believe that these parameters are important in making decision about shunting. So what do we need to do? We need the patient lying comfortable on his side. We need to one wide lumbar puncture needle. We use 18 gauge needle. And through three-way stopcock, we can deliver with constant rate using infusion pump fluid and also measure pressure with external transducer. Signal from transducer, this is electrical signal, is going to bedside monitor and further through the digital link to computer running software ICM Plus used for analysis of intracranial pressure. I will show this part of the slide in magnification a little bit later, as it's a little bit important. So at the beginning, we measure baseline pressure, and then when we start infusion, we observe increasing intracranial pressure and saturation at certain point. On the top of this, we need to observe the waveforms of intracranial pressure. These are pulse waveform, respiratory waveform, you hardly see this, and also slow waves. They are overlapping in time domain, but in spectral analysis, they show nice separate peaks. This is a pulse amplitude and first harmonic, so this frequency is equal to frequency of heart. Then it's a respiratory parameter equal to rate of respiration, and then power and peak associated with slow waves of intracranial pressure. What we measure? We measure baseline pressure. When we start infusion, this is grayish area, we observe increase in intracranial pressure. We usually use infusion 1.5 mils per minute, sometimes 1 mils per minute when baseline pressure is increased. Then we measure heart rate. This is for us a good indicator that pulse amplitude is easily detected by the computer. Then pulse amplitude, which is increasing proportionally to infusion, to intracranial pressure, you see. Therefore, we are working all the time above P optimal. Amplitude increases with intracranial pressure without any delay. And also we have another parameter, just a control parameter, but having its peculiar clinical significance. This is correlation coefficient between slow waves in amplitude and mean intracranial pressure. The running window around 4 minutes, and then calculations can be repeated as fast as we can, as we want here every 10 seconds. Correlation coefficient shows how fast amplitude is changing with mean intracranial pressure. Therefore, before we start infusion, we usually see low RAP, low correlation. It means we are in the zone of good compensatory reserve. But when we start infusion and we start adding the volume to the system, RAP usually as amplitude and intracranial pressure are changing in the same direction, is increasing to +1. Which parameters we evaluate during infusion study? This is baseline ICP, pulse amplitude at the baseline, resistance to CSF outflow, elasticity, once again, RAP, correlation coefficient between amplitude and mean pressure. This is this interpretation here where we have the linear relationship between pressure and the volume on pressure volume curve. RAP is 0, this is good compensatory reserve, and RAP is equal to 1, where we are switching to exponential part of pressure volume curve, and the compensatory reserve is poor. And then we calculate also slope of amplitude pressure line and power of vasogenic waves. Important things about the interpretation of amplitude at the baseline and the slope of amplitude pressure line. In works of Per Christian Ide, it appears that higher pulse amplitude associates with those cases who really have a good chance to improve after shunting. And higher slope of amplitude pressure line, according to Professor Anilev from Rome, higher this slope is associated also with cases who improve after shunting. And here is a screenshot from ICM Plus. After the test, automatically we see rise of intracranial pressure recorded. This is blue, with load of vasogenic waves, and that is interpolated by theoretical pressure rise curve from the solution of the model. Then pressure volume curve, good exponential fit, and the relationship between amplitude and intracranial pressure, good linear fit. Now we can take a look about examples of infusion study in different types of CSF disorders. Baseline intracranial pressure is normal. Resistance to CSF outflow calculated as the difference between this level and this level divided by infusion rate. It's normal. Normal resistance to CSF outflow is from 6 to 10 millimeter mercury per mil per minute. And pulse amplitude is very well responding to changing the pressure to start of infusion, rising almost identically as intracranial pressure, a little bit different scale. So this is normal CSF circulation. In contrast, normal pressure hydrocephalus. Still normal baseline pressure, around 10 millimeter of mercury. We treat baseline ICP as normal as long as it's measured as lower than 15 millimeter of mercury. But average in NPH is around 10. Then after start of infusion, pressure starts to increase, but to higher plateau, therefore resistance to CSF outflow is increased, is higher than 13 millimeter mercury per mil per minute, which is our thresholds we use in Cambridge. Then pulse amplitude also increases and also shows the same slow vasogenic waves. RAP 0 showing good compensatory reserve, it's normal pressure hydrocephalus, at the baseline, and then increasing to +1 when we start infusion. Then atrophic brain, low or very low intracranial pressure, no vasogenic waves that much, very sluggish rise of intracranial pressure, plateau low, showing low resistance to CSF outflow. Pulse amplitude doesn't change that much when intracranial pressure is changing. Very specifically, low RAP at the baseline, good compensatory reserve at the baseline, and also good compensatory reserve during the test. Acute hydrocephalus, little bit higher baseline pressure, around 15 millimeter of mercury. So this is a threshold between normal elevated intracranial pressure. According to Tony Marmaru, really elevated ICP starts from 18 millimeter of mercury, so we are a little bit more cautious. Brisk rise to high intracranial pressure and plateau, but also appearance of the very high slow vasogenic waves. Look at the magnitude of 15, 20 millimeter of mercury. The same rise of amplitude and the slow vasogenic waves seen in amplitude thread can be seen here. Very specifically, of course, resistance to CSF outflow is elevated, elasticity also is elevated, and according to our measurements, RAP is close to +1 before we start an infusion and during the infusion. There is no good compensatory reserve zone here whatsoever.
Marek, can I ask a quick question?
Yes, please.
We always get worried when we hear normal in science and especially in medicine. But could you elaborate in a timely fashion when you wish, where's the evidence that a normal value is under 10 millimeters mercury per mil per minute, and where's the evidence for that?
Yes,
that would be really good to share.
There is evidence, but evidence was so old that I didn't dare to introduce it here. It's very well established, but I can tell you, there was a professor of neurology in far north in Sweden, Professor Jan Ekstedt, who was doing infusion study in patients which are admitted for hydrocephalus, but also healthy volunteers. He ran the geriatric department in UMIA. And he did a lot of infusion studies in patients with normal CSF circulation, no symptoms of hydrocephalus, and we know from his work that has been published, obviously, that very well established large groups of patients, normal values of resistance to CSF outflows is from 6 to 10 millimeter mercury per mil per minute. And if you have resistance lower than 6, you may be looking and thinking about spontaneous intracranial hypotension, CSF leak. If you have resistance much higher than this, and by consensus that has been taken as a 3 millimeter mercury per mil per minute, so above 13 millimeter mercury per mil per minute, that has been established also by several authors and trials. I will tell a little bit later about this, that this is increased resistance to CSF outflow.
Thank you. That was spot on. Very grateful. Thank you for clarifying that.
Idiopathic intracranial hypertension, the last of the possible CSF dynamics disease. We have very high intracranial pressure, 30 millimeter of mercury, with vasogenic waves as well. But the resistance to CSF outflow is low. Elasticity is increased, and also compensatory reserve at the baseline and during infusion study is increased. Compensatory reserve is exhausted. Therefore, if we want to write the kind of the roadmap, we can start to play. ICP along this axis are resistance to CSF outflow along y-axis, and here are just for orientation numbers. We have 4 quadrants. Very important that the quadrants are separated with by each other. This is a straight line, some type of irregular shape. Therefore, there is a great uncertainty whether we are here or here, here or here, or here or here. First quadrant, it's a normal CSF circulation, normal intracranial pressure, and normal resistance to CSF outflow. Here are patients with a normal CSF dynamics plus atrophy somewhere here. Then this quadrant, it's normal pressure hydrocephalus, low ICP, and increased resistance to CSF outflow, above 13 or 17 millimeter mercury per mil per minute. Here is acute hydrocephalus. So we have both high ICP and high resistance to CSF outflow. Then pseudotumor cerebri, idiopathic intracranial hypertension. We have high intracranial pressure, but normal resistance to CSF outflow. So the tumor cerebri is not, in most cases, it's not a disease of disturbed CSF circulation. it's a problem, in most cases, it's a problem with the venous blood outflow. So, in summary, who needs a shunt from CSF perspective? Here is normal pressure hydrocephalus, patient needs a shunt. Here is atrophy, low ICP, low resistance to CSF outflow. She doesn't need a shunt. Here is acute hydrocephalus, post-subarachnoid hemorrhage, but not necessarily post-subarachnoid hemorrhage. It may be post-meningitis. We can see very high rise in ICP. The infusion test is discontinued here because we don't want to breach the safety limit for ICP, which by consensus is 40 millimeter of mercury. And then finally, patients with normal CSF circulation, he doesn't need a shunt, but he needs observation and perhaps repeating of infusion test. Now we need to devote few minutes to cerebral blood flow and CSF circulation. When we want to study both of them, we need to change the model. Because look at this, normal model was ideal, fantastic. We still use this after 40 years, but there is no blood flow in this CSF circulation. So to CSF circulation, here is the brain in the box, and light blue is cerebrospinal fluid. We have the circuit is presenting or representing blood flow. Arterial blood pressure, arterial blood inflow. Here is compliance of arterial blood bed, cerebrovascular resistance with autoregulation, venous compliance, bridging veins resistance, and then outflow to sagittal sinuses. And here, this part is production of cerebrospinal fluid and absorption of cerebrospinal fluid and compliance of CSF space. So, part responsible in this electric model for CSF circulation, equivalent to this CSF circulation model by Tony Marmaru, is hidden here. First of all, interpretation of slow vasogenic waves of intracranial pressure. If we do infusion study, here is ICP increasing during infusion with transcranial Doppler measurement of cerebral blood flow velocity in middle cerebral artery, we can see that vasogenic waves of ICP are not, in fact, just the vasogenic waves of ICP per se, but is provoked by pulsations of cerebral blood volume. These two sets of waves are absolutely synchronized. Then autoregulation and resistance to CSF outflow. We can measure autoregulation with TCD using correlation coefficients between blood flow velocity and cerebral perfusion pressure. This correlation is called MX. MX plus, close to +1 shows disturbed autoregulation. Negative MX shows good autoregulation. There is not very high, not very strong, but significant correlation between MX and resistance to CSF outflow. Patients with high resistance, it means disturbed CSF circulation, have a better autoregulation than those patients having normal resistance to CSF outflow. They have all worse autoregulation. Those patients, all of them have the clinical symptoms. And then we can see that those patients with clinical symptoms but normal CSF circulation probably have a worse autoregulation, which is really significantly indicated by loss of autoregulation. Those patients with clinical symptoms but increased resistance to CSF outflow have no evidence of cerebrovascular disease. Obviously, there are a lot of patients in the middle. We can study also cerebral blood flow using PET scanner. We took the patients needed in need of infusion study to PET scanner and did two measurements at the baseline with low intracranial pressure and during infusion, and then looked at cerebral blood flow in white matter. Here is a picture for normal volunteers, and here is a distance on the x-axis from ventricles towards the gray matter. So we can see that in normals, the distribution of cerebral blood flow in white matter is absolutely horizontal. In patients suffering from normal pressure hydrocephalus, it's an evident and very strong relationship between distance of ventricles and baseline cerebral blood flow in white matter. It's decreasing towards ventricles. And also cerebral autoregulations got its own shape. Here, close to gray matter, here, close to the ventricles. Significantly lower static rate of autoregulation close to ventricles than close to gray matter. Back to resistance to CSF outflow. We know several thresholds. 1982, Bergens and Gieris looked at the threshold of 12 millimeter mercury per mil per minute, so a little bit lower than we are using now in Cambridge. We use 13, but not dogmatically. Positive predictive value and negative predictive value, 100%. Ideal, bingo. They published this in the brain. 15 years later, Dutch study for normal pressure hydrocephalus. They looked at different thresholds and they found that the threshold 18 millimeter of mercury per mil per minute is better, and it gives positive predictive value 92%, but negative predictive value was only 34%. Not very good in comparison to results of this study. The 2009 European trial, no correlation between resistance to CSF outflow and outcome whatsoever. And finally, that was a retrospective study, 2018 in Cambridge, but a big number of patients, 310. There is a significant correlation between resistance to CSF outflow and outcome after shunting. How to understand this diagram? We can understand using so-called vascular or even related to age, just general comorbidity. If comorbidity is low, we simply can differentiate between patients who have a chance to improve and possible improvement using resistance to CSF outflow. If our resistance to CSF outflow is higher than 18 millimeter of mercury, we may be certain that there is a chance of improvement, decent chance of improvement. From 13 to 18, or even 12 and 18, it's possible improvement. For low resistance to CSF outflow, everything is rather impossible. But if we have higher comorbidity, doesn't matter how high resistance to CSF outflow is, whether it's above 20 or 25 millimeter mercury per minute. We don't have that much chance for improvement. Nevertheless, taking all this methodology of measuring cerebrospinal fluid dynamics, we can say that over the time when we came to Cambridge and then continue to use infusion study, outcome of our patients improve. Obviously, it will saturate somewhere, I guess around 82, 83%. Hope not go down. Nevertheless, all our efforts, our works are step by step, sluggishly producing improvement of outcome of our patients. But only half of patients coming to our clinic don't have any shunt before. They can have a shunt, and another part of our studies is related to how to say with higher fidelity that this shunt is blocked, needs a revision, or doesn't need a revision.
The improvement of a shunted patient, of course, depends primarily on the correct diagnosis, but also to a large extent on an optimal functioning of an implanted system. And detection of a failure, effective in vivo assessment of a shunt can considerably support patient's management. The implanted shunt dramatically changes the system of CSF circulation. The Marmaru model should be altered. The shunt is represented by this extra branch with one-way conductive element, non-linear resistance, and the reference pressure. Please note that the reference pressure in shunt branch is different than in normal physiology. It depends on the site of the drainage. Moreover, for a VP shunt, this pressure will be different depending on the body position. What can go wrong with the implanted shunt system? It can underdrain, it can be blocked proximally or distally, but it also can overdrain. In order to diagnose the problem with an implanted shunt, we need the knowledge about hydrodynamic properties characteristic of the device and the understanding of principles of its operation. For many years, we have been running the shunt testing laboratory, where almost all the shunts used in clinical practice have been tested. The results were published in dedicated reports and in scientific press. Furthermore, are incorporated in ICM Plus version for Infusion study. The pressure flow relationship for all the shunt system have been measured and relevant hydrodynamic parameters have been calculated. Also, the influence of various factors like temperature, pulsatility of the pressure on valve function has been investigated. It's important to note that most of valves are controlling the pressure as it's shown here on figure A. This is plot pressure against the flow through the valve. The slope of the curve is determined by resistance, hydrodynamic resistance of the device. The connection of the distal drain can significantly increase this resistance. The steeper the slope, the smaller the resistance. Very few devices can control the flow. This is a characteristic of Orbis Sigma valve, which can stabilize the pressure in the range between 5 to 25 millimeters of, it can stabilize the flow in the range between 5 and 25 millimeters of mercury, regardless the pressure across the valve. Some systems come with the hysteresis. Our methodology of in vivo shunt assessment is based on our experience in studying CSF dynamics and data from the shunt laboratory. The method uses as infusion test and appropriate interpretation of the results. Most shunts have pre-chamber, which allow us easy access to CSF space. 2 butterfly gauge 25 needles can be inserted, one for measurement, one for infusion. The advantage of the infusion test, we can see here the result, is that not only we evaluate the baseline state, but also we can assess how the system is responding to an extra challenge of the infusion. On the basis of the laboratory testing, the appropriate values for each valve and each setting level can be calculated like it is shown here. And this is our reference in valve assessment. All equipment can be mounted on a small trolley, infusion pump, pressure monitor, computer with ICM Plus software. This trolley can be easily taken to patient bed anywhere in hospital. Testing under drainage. We found that for assessment of under drainage, a key parameter is a critical pressure. Pressure value that should not be exceeded during infusion with a properly functioning valve. Again, the critical pressure can be calculated on the basis of the laboratory results as hydrodynamic resistance of the valve, value from the laboratory, applied infusion rate, operational pressure of the valve from the laboratory, plus 5 millimeters of mercury. And here the critical pressure has been marked with red line. We've got two examples of properly functioning system and under drainage. Intracranial pressure during infusion never exceed the critical value. So we can conclude this valve is draining this properly. For this system, during infusion, intracranial pressure exceeded significantly the critical value, so we may conclude that the valve is under draining or maybe even blocked distally. An important point. As it has been already discussed, the ICP signal has its different pulsatile component. Our method is based on the measurement of intracranial pressure. Therefore, it's essential to confirm that the readings are these of ICP. The detection of pulse amplitude in the signal, as you can see here, nice detection of pulse amplitude, and here also you can see the respiratory component, is critical. If the signal monitored from the valve pre-chamber does not have the pulsatile component, it is a strong indication for the blockage of the proximal end. And here we've got a typical result of infusion study for a system with proximal blockage. We've got flat pressure. You remember, these are recording from the shunt chamber. So the baseline is, on the baseline we've got flat recordings without any pulsation, no detection of the pulse amplitude, and consequently no detection of heart rate. The system is still draining distally. The pressure is nicely stabilized. We observe the very steep response to the start of the infusion, which is due to the very small compliance only isolated shunt chamber. It is important to be aware that measurement here represents the pressure in isolated shunt chamber, doesn't provide any information about real patient's ICP. For some valves, like strata, the occlusion maneuver can be performed. Strata has a delta chamber, we can press on delta chamber. The pressure is, during the infusion, when the plateau is already reached, we can occlude the outflow from the valve by pressing on delta chamber. This way, we mimic the situation as if the valve is not draining. The pressure response will provide again some information about the performance functioning of the system. The pressure response would be moderate when the communication with CSF space is still working. But if it increases to the very high values, it will confirm the proper blockage of the ventricular catheter. It could happen that the choroid plexus is ingrowing into the lumen of the ventricular catheter. This is partially blocking the drain. In such circumstances, the pulse amplitude, however present at the baseline, will fade throughout the infusion. Overdrainage. The excess is also undesirable. The cause of excessive drainage can be various. Low hydrodynamic resistance of most valves may enhance this risk significantly. Most common is postural overdrainage. A simple pill test can help to reveal whether the system is working optimally. And we've got two recordings taken via Omaya reservoir or shunt chamber for two patients. No shunt and overdraining shunt. For non-shunted patient, the baseline in horizontal position is normal. Then we record when patient in upright position, the pressure would decrease, but to moderate value. And when patient is back to horizontal, the ICP should be back to the baseline value. Contrary, in overdraining, in a patient with overdraining system, baseline would be low. Then when patient is set up, the ICP decrease is excessive, could be to very low negative values. And when patient is back to horizontal position, the intracranial pressure stays lower than the baseline, and this is due to excessive drainage in upright position. Slow waves of intracranial pressure. In shunted patient, increased activity of slow waves, which is detected here, associates with decreases in recorded ICP. Increased slow waves results in excessive drainage and consequently significantly decrease of intracranial pressure recorded, even to very low values, negative values. As you can see, this zero, our zero is here, but here we've got minus 10 millimeters of mercury. So, if we try to put our conclusions, our reasoning together in one picture, it is, you can see the clear differences between different pictures of CSF dynamics. Who needs a revision, who doesn't? This is a nice picture of a result of infusion study for a patient with properly working shunt. What we see, this is ICP, this is pulse amplitude. First of all, pulse amplitude is recorded. It confirms that the ventricular end is patent. There is a connection with CSF space. The baseline ICP is moderate, is normal. However, it doesn't mean necessarily, doesn't carry information about proper functioning of the system, particularly in NPH when baseline pressure is never increased. And now the response to the infusion, it always stays below critical pressure. So we can conclude this system is draining distally well. Contrary to this example, this patient, the baseline is moderate, detection of pulse amplitude is okay, so ventricular end is okay, but the response to the infusion is really excessive. So it's a strong indication for distal underdrainage or even blockage of the shunt. This is an example of the block, but on the proximal blockage. No detection of pulse amplitude. The shunt is draining distally. Here we've got very steep response to the occlusion. So the shunt is draining distally, but proximal drain is blocked, so revision is needed. And here is an example of the abdominal drain blockage. So again, there is a need for revision. Good that proximal end is working, the pulse amplitude is detected, the ICP is moderately increased, and a very steep response to the infusion. So if we come, it brings us to the conclusions. We believe the knowledge of CSF dynamics is helpful in guided management of NPH. Infusion test is minimally invasive. We've got less than 1% infection rate. Resistance to CSF outflow correlates with outcome after shunting. In NPH, white matter cerebral blood flow is compromised around ventricles. And shunt may be tested in vivo. Yearly saving from unnecessary revisions in our hospital is estimated for around 1 million British pounds. Thank you very much. And the last important point, my very sincere acknowledgement to all the contributors, our co-workers, PhD students. Yes, starting from Professor Pickard, who brought us to Cambridge, really helped us a lot and taught us a lot.
And he was our master.
And he was our master. So thank you very much. You can see people from all over the world, France, Europe, United States, Colombia. Here is actually a very interesting person. Okay, Colombia, son of Solomon Hakim. So,
thank you.
Thank you very much.
Wonderful, absolutely brilliant. I enjoyed that every time and time again. It's a fantastic review of the not only the knowledge and the science and the data on infusion studies, but the principles behind CSF dynamics, which you've mastered so well.
Yeah, but this is CSF dynamics. According to the numbers, evidence from the literature, this is only 34% of troubles we can see in hydrocephalus. Rest belongs to the clinicians, the scientists doing neuroimaging, chemists, and neuropsychologists and other specialties.
Thank you very, very much, Marek and Sophia, once again. I've got questions, but as always, but I think it'd be good to just turn the platform to everybody, and already some questions that are coming in, and lots of comments and compliments, as expected. So the first question from Nikolai Tonchev.
Can you disable the screen so the audience can see you in a full screen?
Okay. We can
on
then
the top.
Yeah.
Perfect. Thank you.
So Nikolai is asking that according to your experience and studies, he's putting the question, does it mean that a patient with a high opening pressure by lumbar puncture over 25 millimeters of mercury, or water rather, needs a shunt, and how could a practitioner evaluate the approximate chance of bettering the condition after shunting? I'm not sure if he's able to join and ask the question directly himself, but this is his question. If you want me to repeat it, I can read it again.
No, that's okay, that's okay. 25 millimeter of mercury in lumbar puncture happens very, very seldom, simply because we exclude patients with high intracranial pressure, looking at MRI, to have any adverse effects, and that may be severe, when lumbar puncture is that high. We see them from time to time, but these were patients in idiopathic intracranial hypertension group. We very, very seldom see patients classified initially as a possible NPH with such a high intracranial pressure. They usually improve following shunting, and obviously, but this is not really a part of the intention in evaluation of the patient.
Thank you, Marek. I've read that question that it's 25 millimeters of mercury. He's written 25 millimeters of water, but I'm sure that's a mistake. It's 25 millimeters of mercury. Thank you.
25 millimeter of water, it's 13 times lower than in millimeter of mercury. So this is normal pressure. Normal pressure, even too low pressure, because in millimeter of mercury, that will be around 2-3 millimeter mercury. So in such a low pressure, we cannot say anything about the prognostication for shunting. We need to know resistance to CSF outflow.
Okay.
Such a low pressure below 6 millimeter of mercury may indicate idiopathic intracranial hypotension.
Yeah. Thank you, Marek. So the next question from Professor Andre Grottenhaus from Netherlands. I can only agree, he's commenting, with their findings in testing shunts in vivo. It helps to avoid unnecessary revisions. But in our clinics, this is from Professor Grottenhaus in Netherlands, but in our clinics, we have seen way more negative pressures in upright position in non-hydrocephalic patients. And he's put in brackets, we studied such pressures in patients with other diseases that needed EVD or ICP monitoring. So we saw it regularly dropping to below -10. I mean, that's a comment, and it's a useful comment. If you want to add anything to that.
Yeah, no. In patients without shunt, we always sit up the patients after infusion study. When we're doing this with Omaha reservoir, we see the lowest pressure -8 millimeter mercury. Okay, the lowest. This is our, whatever is below this, it's we classify this as a point for over drainage. So
there is one important point, sorry to interrupt, because when you measure a value, your result was always biased with an error. So how precise, when is your reference point, where is your zero level? We measure, we put our zeroing when we measure as a ear level. Of course, now, I want to raise this point about measurements. Always might be the error about the zeroing level, about precision of your measurements.
And when you're doing infusion study horizontally, and then sit up the patients to see what will be the pressure in vertical position, you need to re-zero the transducer, keep the same reference zeroing point. So always use the ear, it's much simpler.
Thank you for that. Before the next question from Guy Ilo from Israel, just wanted to make a quick comment, if I may, regarding this very important point, because with the advent of new technology, particularly with the new telemetric reservoirs, which are now available, that connect with shunts or even followed from endoscopic ventriculostomy, as we put plenty here and others have around the world, it's regularly seen. In fact, it's universal that when the patients are sitting up or standing, the pressures are always negative, whether they've had any treatment. So from -6 to -10, even as low as -15, we've seen. So it's very well recognized now because of monitoring using the telemetric devices.
Yes.
A question from Guy Ilo from.
Sorry, can I answer to this comment? It's very nice, it's very good, it's very important. Yes, we physiologically all have a little bit negative pressure when we stand up. Okay, you and me, no shunt, -8 down to -8 is a normal. This is the lowest pressure we measured in Cambridge in patients without the shunt. And the group of the patients we are investigated this way, it's around 2,000 or 3,000. We always try to measure this. Below -8 is excessive. It may be excessive negative pressure may be during cerebrospinal fluid leak, which is not that much in common these days.
Marek, a comment about that, and which I think is very important. Thank you for sharing that. ICP is not static, as you know. It's a waveform, and the waves can really vary.
Yes.
So to come down as low as -10 and below and -12 and 15, but the mean pressure you're referring to should be no lower than -8.
Yeah.
Okay.
One minute averaging.
Thank you. Wonderful. There's lots of questions. If I may come on to Guy's question, he's asking, is there any impact of intra-abdominal pressure on the evaluation process?
Exactly. And it was when I was talking about it's a very important point, because when I was talking about Marmaru model for a shunted patient with the shunt branch, I made the point that the reference pressure in this branch is different than the physiology. We create a physiological connection between ventricles and draining side, let's say if it's abdomen, so it will be abdominal pressure. In pregnant women, in obese patients, this pressure will be increased. It's
in patients after head injury, compartmental syndrome, very high abdominal pressure may happen. Maybe 30, 40, 50 millimeter of mercury. Can you imagine?
So we didn't have time to talk about it in this presentation, but of course it can be this sort
should be taken
into account. It can be done, no problem.
It is included to some extent in this Zofia formula for critical pressure in this +5 millimeter of mercury. But I don't know whether this is a good number, and I don't know whether this number is the same for everybody.
It can be as much as 10 millimeters of mercury, and of course the critical pressure, our reference point should be adjusted by this value. It's important that we are aware. Thank
you. I'm going to, that was a gem. Thank you. I'm going to try to get as many questions as possible. So if we've got quite a lot, if that's okay. So Eric Sharpong, what advice can you offer those who do not have access to infusion studies in their hospital? If you want to make a comment, I'm happy to do so as well. Please, please.
Come to Cambridge and we will show you, Sofia will show you how easy it is.
If you are desperate, you can take a butterfly needle. First of all, I would look at, put into the reservoir and see whether the pressure, how far is pressure going. However, if you have a block of proximal end, your result won't be reliable.
Okay. Thank you for that. Mahmoud Shwaib is asking, maybe what we could do is send him, if you can email us, he's asking if you can recommend some readings on the topic as a start on the topic. I could always suggest to him to read some of your 140 publications on this subject. So I'm sure we could maybe guide him in the right direction. Again, well, I'm going to skip the next. It's not more of a question, it's more of a comment. The next one from Anna Ferreira. Thank you very much for the great lecture. Is it possible to make a measure using an EVD catheter? And so also next one, could it have any clinical utility, for example, to predict ideal initial pressure in a variable valve?
Yes. We do some studies through EVD, particularly in patients with post-traumatic hydrocephalus on ICU. The important point is to switch off EVD at least half an hour before you start the measurement. But EVD access, it's absolutely legible access to cerebrospinal fluid compartment.
Wonderful, thank you. Another comment from Professor Grottenhaus, he's making a comment that 0 is at the foramen of Monroe, so indeed the ear level, in agreement with what you've said. So this is an interesting question from Piero Andre Opido. Have you applied the infusion test study before and after ETV? And of course, this is a, I think, important question because here is indicating, although it's not said it, that ETV done for what we may refer to as intraventricular obstructive hydrocephalus. A comment for all those listeners who may be excited, there is a working group put together by the CSF task force. That's a long-term project to reevaluate and maybe redo a new classification for hydrocephalus because we need that. It's simply not good enough to have obstructive communicating. So if you have any comments about that regarding ETV following what I presume is referring to as intraventricular obstructive hydrocephalus and infusion studies before and after.
Yeah, we observe this quite frequently. In fact, our colleagues, our doctors, neurosurgeons, when they are doing ETV, at the same time, they implant Ommaya reservoir, through which, if they are in doubts whether CSF dynamics has been improved significantly by ETV, may be repeated. And then, obviously, sometimes we see the improvement of CSF parameters, particularly resistance to CSF outflow and opening pressure, but sometimes we don't see at all. It means that the obstructive hydrocephalus in these cases were followed by hydrocephalus due to the blockage of CSF flow on the brain convexity, little bit higher. And this is very, very frequent situation. We see obstructive hydrocephalus in MRI, particularly if you don't see oscillatory CSF flow through aqueductus cerebri. We can say that almost sure ETV should help, but sometimes situations that we do ETV, but the blockage of cerebrospinal fluid is distributed. It's always more distal.
Marek and Sophia, can I ask, just to clarify, would you recommend doing infusion test if there is clear intraventricular obstructive hydrocephalus? So
No, Zosia doesn't recommend.
I wouldn't do hyperpuncture, but we do only for those who have Ommaya inserted.
Wonderful.
If it's obstruction, we don't.
Thank you for clarifying that. That's an obvious point. Thank you. Wonderful.
We don't do, yes, that's very true. We don't do infusion test before.
Okay.
Always patient is, LRI patient is checked before lumbar puncture, before lumbar test.
We have many questions and comments. Thank you for that. So another comment from Professor Grottenhaus that they've also measured telemetrically patients who've been standing and upright and with similar comments, and thank you for that. So question from Sevgi Ugur from Turkey. Welcome. So he's saying hello, and do you suggest ETV, endoscopic tracheostomy, for normal pressure hydrocephalus patients? If so, which pressure is best to select ETV over ventricular peritoneal shunt? If you have no comments on this, I'm happy to make a comment, but you're welcome to please make a start.
No, but generally we don't recommend shunting, ETV in patients with normal CSF dynamics as we measure. But we are not deciding 100% about who really needs a shunt. And sometimes these patients had the ETV done. And this is a then question for us whether this ETV changed CSF dynamics or not. But personally, I wouldn't do ETV for normal pressure hydrocephalus.
Thank you both. A quick comment about that. The evidence is, although there was literature evidence that had some success, I think the vast majority of people around the world deal with the NPH agree that ETV is not.
Yes, sometimes it is. Sometimes it is. Yes, very true.
Shunt is by far the better option. And we're going to have a session on NPH, in fact, two, and won't elaborate. So next question from Corrado Lacarno. How to apply these considerations in 3 critical scenarios: failed endoscopic third ventriculostomy, 1, 2, decompressive craniectomy, or number 3, cysternostomy. Is there some converse calculation? I'm not sure what's meant here, but maybe if this could be clarified. But anyway, we'll go to the next question. Let's go to the next question.
Yeah, I can tell you.
Yeah.
With craniectomy, the compressive craniectomy, infusion study doesn't produce any kind of information useful. Because cerebrospinal fluid dynamics is disturbed. Environmental pressure is atmospheric pressure.
Yeah.
It cannot be. We need to wait until cranioplasty. So from this point of view, early cranioplasty is beneficial. It means reduction of complications secondary to hydrocephalus.
To restore the box. Yeah.
To restore the box and to measure its parameters.
Thank you for that. One of the questions which you put in the comment section, if I may just ask that now, was what about when viscosity is fluctuant because changes in CSF proteins in a patient with a shunt? Do you think that makes a difference? It's an argument that could be easily made in fluid dynamics, whether blood is Newtonian or not. But what about CSF? Do you think there's any merit in taking viscosity variations into account?
No, cerebrospinal fluid is Newtonian. Unless viscosity increases in meningitis or just past subductal hemorrhage is full of blood. Nevertheless, we know what to do in such a cases: extraventricular drainage and so on and so forth, draining as much as we can. We're trying to apply draining first and then be sure that it's not particularly, there is no particular reason for treating blood as or cerebrospinal fluid as non-Newtonian, and then do infusion study.
We have impact in shunted patients. We've done tests in our laboratory using micropores mimicking the blood cells. But this is another story. Microspheres, but it's another story.
Okay, thank you for that. We won't expand on that at the moment, but thank you. Okay, a question from Selkuk, who's saying, do you take CSF samples for microbiological and or biochemical analysis during the procedure?
Yes, we do. We try to minimize the sample. When the bigger sample is needed, it will be mostly for the lumbar punctures patients. So we do the UMIA way. So we measure the baseline, then we take the sample, and then we infuse a bit to go back to the baseline. So
the important point also is that according to the microbiological test after infusion study, inflammations, infections, less than 1% of our tests.
Thank you.
So it's not very invasive. Of course, during the test, we need to try to be sterile.
we had an audit run over 3 years to assess the infection rate.
So it's definitely much lower than the risk of infection after normal lumbar puncture in a bed on neurological ward.
Thank you both again for that. Another comment, an interesting question. I can see where this is going. This is really good. It's a rare scenario from Professor Grottenhaus again. He said that maybe it is too much to bring this up, but what about testing in negative pressure hydrocephalus in patients who have lost their brain compliance, such as, for example, after major subarachnoid hemorrhage or ICH or trauma? So patients who've got hydrocephalus on a scan, but it's very low pressure, negative pressure. Have you got experience with those infusion studies?
We try to show this saying and naming these patients a brain atrophy. Hydrocephalus generally, this is finding the answer to important question, whether there is too much water in the brain or not enough brain in the skull. Okay, so you need to judge what is reason why you see enlarged ventricles.
This is when we...
So once again, very low resistance to CSF outflow, very low elasticity, RAP at the baseline 0, no slow vasogenic waves, pulse amplitude not reacting to changes in ICP. This is brain atrophy. And this is probably the case where Professor Grottenhaus asked his question about.
It's really good. Thank you. Thank you. And thanks for such fluent feedback about what to expect. A question which was along the lines of what I was thinking to ask you, although it's just disappeared. I'm going to ask it anyway. Have you got any experience of doing infusion studies and monitoring the pressure and the feedback and the waveforms when someone has already got a telemetric device and see if it correlates with the feedback?
No, but I know that colleagues from Copenhagen, Denmark, Marianne Euler, and her students were doing these bits and pieces of evaluation of the telemetric. They published recently something, and we can invite them for another talk. Telemetry is very important. It's interesting.
Yeah.
It's got a lot of disadvantage technologically yet, but it's growing. It's coming here. This idea to put pressure transducer in the brain permanently.
Another question and a comment. David Sinclair, wonderfully insightful and instructive talk. In post-subarachnoid hemorrhagic hydrocephalus, can you discern a reduced reabsorption from increased CSF choroidal pressure, in brackets, but inflammatory mediated, and in brackets again from overproduction, as this may have implications in treatment? So basically, can you discern between whether it's a reabsorption problem or
overproduction?
CSF production, yeah.
The system evaluates everything. So solution of Tony Marmaro model, it means identification of the model, gives you also estimator of CSF production. And sometimes it's increased. Sometimes it's in really physiological level, 0.3, 0.4 mils per minute. Unfortunately, this parameter for, this is just mathematics, optimization of this model or estimation of this parameter has got very, very low accuracy, unfortunately. low sensitivity of the model to this spectacular, to this important parameter. Yes, there is a lot of white spots on a map of hydrocephalus and its physiology, and one of the important points is the measurement of CSF production. We cannot, at the moment, we cannot do it properly. We just estimate this.
Thank you. Another comment from Ravi Maraju, many positive comments. If I was to read them all, we'd be here all day, but thank you for that, Ravi from Cardiff, saying excellent update and many thanks. I have a question, if I may ask, since there's no more questions from the, actually, my apologies, more have come. But can I just ask my question anyway, if I may? You know that shunts are advancing. There's more than 170 on the market. And we are now, we know that inventors and production is looking into intelligent shunts that can tell how much they're draining per minute or per hour. And you can see where this is going with applications and artificial intelligence. Do you see still a merit, as perhaps I could see and others may see, for an infusion port and an interrogation port to test still the CSF compartment and its compliance to merit getting data with infusion studies? Because when shunts can tell how much they're draining, whether they're on or off and so on and so forth, still it would be good to get an up-to-date interrogation of the CSF compliance and compartments. What are your thoughts about that?
We've been also always looking at infusion tests as something very simple, and giving the good feedback for, or useful feedback for neurosurgeons. So very nice to us, giving us their feedback from the operating theater, from the table. That's absolutely important. This is why we say, okay, we know who needs a shunt, who needs a revision, but we always add from the CSF dynamics perspective. Really improvement in the shunt would be not the port for infusion study, but making a shunt with as an active pump.
Yeah.
And active pump would be absolutely ideal. The problem is, because we tried many times, the problem is with the power delivery and power consumption. That would improve a lot. We will have important information about the draining rate, draining volume, even more important. And shunt may be then converted to almost in all cases scenarios lumboperitoneal shunt. Think about this. That would be absolutely great. Find a power source. Everybody will be happy. There will be no longer shunting, will be no longer neurosurgical intracranial, let's say, operation.
Absolutely. Interestingly, when we go to the meetings, it turns out that the experts and the surgeons who treat normal pressure hydrocephalus in Japan, for example, the majority of the shunts which are placed in Japan for NPH are spinal. And it just goes to show that you can do both. And very much this is a cultural differences as well, which is when I'm not talking to national cultures, I'm talking surgical training and how one's been indoctrinated. So we could easily do lumboperitoneal shunts more in the United Kingdom and in Europe.
But the problem is we don't use this properly. We can end up with over drainage, and very significant over drainage. Only if we have the active pump pumping the volume of cerebrospinal fluid with certain rate, we can be sure that we avoid over drainage.
Yeah, that's a very good, solid point. I absolutely agree. Quick comment again from Professor Grottenhaus. I think this is important, so I'm just going to mention this. He's commented about the situation where you've got normal pressure, or let's say low pressure hydrocephalus post-trauma, post-subarachnoid hemorrhage, or ICH, and that, for example, neck wrapping and increasing venous pressure, basically these patients, they improve. And so he's making a comment that this isn't necessarily atrophy. and he's commenting that obviously this is quite a big topic and beyond the scope of this presentation. I would add to that even if you do nothing, they would improve, because we know that in that scenario. But it's a very interesting subject and maybe worth a webinar later on. So thank you to Andre, Professor Grottenhaus, for that.
This neck wrapping is useful in cases of idiopathic intracranial hypotension, the cerebrospinal fluid, where neck wrapping works to raise intracranial pressure, to reduce the clinical influence of intracranial hypertension, which is mainly the pain, headache. We can do this, and it works from time to time.
Yeah, maybe we can encourage them to gain weight temporarily. Yeah. Thank you to both of you. It's been a fantastic educational session and lots of positive feedback, and we are very, very grateful. And I believe we could do more of this sometime with both of you. But wonderful. Thank you to everybody for their participation. God bless you all. Thank you. Wonderful. Thank you, Marek. Thank you, Sophia. And thank you to the whole team in the ANS. Thank you.
Thank you.